So the other general hospital services are like general surgery. So if you take general surgery and the top 10 conditions that are admitted to general surgery, they represent 85% of their hospital admissions. If you take the top 10 conditions that are admitted to an intensive care unit, they represent 75% of their admissions. But the top 10 conditions in general internal medicine represent only less than 30% of our patients. So what does that mean? That means that if you are trying to improve care in general surgery or the ICU, you could say, I'm going to focus on the 5 or 10 most common conditions. I'm going to get those really good, right? I'm going to improve care for 10 diseases, and we're going to therefore have improved care for the majority of our patients. If you do that in internal medicine, you will neglect the majority of patients. So if you take a disease-specific approach to quality improvement in internal medicine, you will neglect the majority of patients. And that's really relevant because right now the province takes a disease-specific approach to quality improvement, right? QBPs are heart failure, pneumonia, COPD, and stroke. But even if we were to get all of the QBPs perfectly right, and improve care, 80% of our patient population would not be addressed by those interventions. Sure.
Of the other diagnoses, how many of these are specific diagnoses that cannot be categorized versus unspecified or unknown diagnoses?
Yeah, that's a good question. Unspecified or unknown is less than 10%. So this is categorization using ICD-10 codes that are then aggregated using the clinical classification software, which essentially tries to take the 10,000 ICD-10 codes and turn them into about 225 clinically understandable and relevant conditions. So definitely not perfect, but many of those are, like, it's not that these are just sort of uncategorized things. Yeah. Any other questions about this? Yeah.
These are your primary diagnoses.
Correct.
In ClinEpi, specifically the field, versus what about secondary diagnosis? What's the degree of overlap in the other where the secondary diagnosis is any one of the other, what, 60, 50 something?
Great question. So in terms of coexisting conditions, the most prevalent, I don't think I put the slide in here, but the most prevalent coexisting conditions are hypertension and diabetes, 30%. Hypertension 30%, diabetes 15%, atrial fibrillation 15%, and then you start getting down into lower categories. Okay, so one of the things that we noticed that was very striking about our patient population, I told you again, it represents 40% of emergency department admissions, is that there has been an enormous growth in volume of our patients. So from 2010, this plot shows 2010 to 2014, and then a little box there updates the data based on our latest data pool. These are relative changes from baseline. So the top line here just represents the number of admissions. So in 2010, there were 25,000 general internal medicine admissions across the 7 sites. And by 2014, 2015, that was 32,000, and by 2016, 2017, that was 37,000 admissions across the 7 sites. So we've seen a 56% increase in patient volume, the number of admissions, from 2010 to 2016-17, with effectively no change in the resources being devoted to this patient population, right? So this is essentially the explanation for hallway medicine, right? That there has been a dramatic growth in the number of patients. And the thing that's scary about this rise is that if you think about the baby boom generation, so the baby boom generation is just turning 75, 76 now, right? So we are just at the tip of that baby boom generation starting to be the group that uses hospital services very intensively. So this projection is likely to only increase over time. And when you think about then, let's look at a couple of other big picture indicators of sort of outcomes or resource use. So if we look at the readmission rate, there has been a slight increase in the readmission rate over time, actually up to about a 12% increase in readmissions from 2010 to 2016-17. Whereas most of the other indicators have been relatively stable. So cost per hospitalization, length of stay has actually gone down, which is understandable given the pressures, right? And may explain part of why the readmission rate has gone up. And use of imaging in hospital has actually gone down. So the way we have interpreted this as clinicians is that we have experienced an enormous rise. We're hearing stories about physician burnout. And I think what we've seen is that our frontline clinical care teams are working harder and longer than they've ever done. And on the backs of their sweat, they've been able to keep a lot of these other indicators relatively stable despite the enormous rise in volume without increasing resources. But I think this readmission rate indicator is a bit of a sort of canary in the coal mine, saying like this system is really straining at its capacity. And if we don't do something soon, we're not going to be able to hold some of these other indicators stable. Yes?
Quick question, sir. Do we know what kind of patient you had in 2010? It's hard to believe the 56% increase. We know there's a baby boomer retirement coming up, population increase in GTA, but it's hard to believe the 56% increase within a 4-year span. I'm wondering if you have, early 2010, you had different denominator, and that truly didn't represent what you had in 2014 that may reflect that, that huge problem.
Yeah, it's a good question. So there's two pieces to that. One is it's a 7-year span. So the 4-year span is 32%. So up to the end of 2017 is at 56%. So 56% over 7 years, still striking. There's been two, I think, major explanations. One has been a change in some care models. So some hospitals have shut down subspecialty wards and increased general medicine wards, right? So it's not necessarily a 56% increase in all patients to hospital. It's a 56% increase in general medicine patients. That's the important caveat. And the other is that I do think the other major driver, though, is population aging and just a huge increase. If you look at the census numbers for the numbers of patients admitted to general medicine, they are certainly higher now than they were before. And that's why you're hearing stories. So this winter flu season at Trillium Health Partners, one of the hospitals in our network, at their Mississauga site. So the last 2 years, they've had to open up their auditorium to take care of patients in the auditorium during flu season. This year, they had to open up their library for patient spaces, right? So like there has been an increase in volume, and I think the data suggests that to be the case, but it is a combination of changing care models and overall change in volume. Okay, so I want to move to talking a little bit about the variations that we've identified using these data. And it's important that you understand something about the way general medicine care is delivered to interpret the data that I'm going to show you. So as with any research around hospital variations, we know that there are big variations between hospitals, right? And a lot of that variation is driven by the different types of patients and cases that are seen across hospitals. Everyone knows that. What's interesting with general internal medicine and creates an important opportunity for research is that there is a process of natural randomization that occurs within a hospital across physicians. So at most of these hospitals, there are 4 or 5 physicians who are on call or working in parallel at the same time. And all of the admissions to general internal medicine essentially are non-elective, which means that the physicians don't get to choose their patients. You get the patient who comes to you who happens to come to the emergency department when you're on call. So it's essentially a random process. And you can imagine it sort of like a patients being sort of like a deck of cards. So 20 patients came to the emergency department in 12 hours, and by the emergency room doctor or the resident on call in the emergency department, those patients are shuffled out to the physicians who happen to be caring for internal medicine patients at that given time. What this means is that over large samples of patients and over large periods of time, to negate things like seasonal effects, you get balance in the patient characteristics when patients come to hospital. Which means that if you see differences that emerge at the physician level, those differences cannot be attributed to patient level differences or case mix differences. And those differences must be explained by differences in practice at the physician or care team level. Does that make sense? And you may choose not to believe it, and I'm gonna now show you some data to try to prove, because like any reasonable scientific audience, you should say, well, that's a big assumption. Sort of, you prove to me that that's okay. Okay. The second important point to understanding physician level care in general internal medicine is that in general internal medicine, there is a lot of handover that occurs between physicians. So most physicians, especially in these hospitals, work for 2 weeks at a time. And so you take care of a bunch of patients, 20 to 30 patients at any given time for those 2 weeks. At the end of your 2 weeks, you hand all those patients over that are still in hospital to the next physician. right? And so if I'm trying to report physician-level metrics around quality, physicians will justifiably ask, how do you know who is my patient versus someone else? In order to try to solve for that problem, we attributed patients to physicians in a very restrictive way. We only kept admissions that have the same admitting and discharging physician and the same Chi-High most responsible physician. So essentially, these patients only had one physician during their stay. We also kept in our sample only physicians who had seen at least 100 patients over the study period, and we removed any long admissions because those can't plausibly be attributed to any single physician. That cuts your sample by about 50%. And it creates an important selection effect in the sample, right? So now you're looking at a healthier population who tends to stay in hospital for a shorter period of time. But that selection effect is non-differential across physicians within an institution. It doesn't create selection effect within the institution, right? It affects all physicians within an institution similarly. So if we still see those differences emerge, those differences cannot be explained by this kind of selection effect that we mentioned. Having shown this now to many, many physicians across the province, easily several hundred, most of them see this and say, and sort of breathe a sigh of like, okay, fine, I'll believe you that these are my patients. Okay. So I'm going to show you now a series of plots where we've been able to look at physician-level outcomes for internal medicine patients. Each of these plots will show the 7 hospitals in these gray bars. Within each box, hospital box, you'll see a bar that represents an individual physician. Okay, the horizontal line and number there represents the hospital median for that, or proportion for that outcome. And then on the vertical bar will represent the difference between the 10th percentile physician and 90th percentile physician at that hospital as a measure of the variation within that hospital, sort of accounting for some of the leaving out some of the outliers. So the first plot I'm going to show you is hospital length of stay. So the first thing that you'll notice is that across the 7 hospitals in the network, there are striking variations in length of stay across each hospital. Not surprising because they care for very different patient populations in very different contexts. But what is striking is that there are large variations across physicians at each hospital, some more than others. So taking hospital A, for example, the median length of stay was 4.9 days, but there's a physician here whose median length of stay is 3.7 days and a physician whose length of stay is 5.7 days, right? And the spread between the 10th and 90th percentile physician is 1.7 days. That is enormous when you think about the fact that each of these physicians are caring for hundreds of patients each year. And so these effects are large and striking. The colored, so there's another piece of information on this plot, which is the shadedness of the bars. So in order to test whether these differences were statistically significant, as opposed to just sort of random noise or sample size effect, what we did was we took the average of the 3 lowest physicians at each site, and then did a pairwise comparison for each individual physician against that average. And the colored bars show statistically significant difference. When we first saw these results, I think I was certainly struck, and the clinicians we showed it to, that these are like striking. I always thought, yeah, some people are quick to discharge patients. I did not think that the effects would be this pronounced across many hospitals. Importantly, there may be system level or hospital level explanations for this effect. It's not all just physician practice. I'll give you an anecdotal example. So hospital C has the smallest distribution, the smallest range here, right? And other hospitals have much larger ranges. There are a couple of important things about hospital C. So the first is that every physician who practices internal medicine at that hospital is trained as a general internist. So they don't have subspecialists. They don't have people who might be maybe doing some clinics during the day and less likely to attend to the ward. Whereas in other hospitals, the models are different. Sometimes family doctors do provide internal medicine care. Sometimes subspecialists provide internal medicine care. So that's one potential reason for the variation being less. The second is that this hospital actually has a very dedicated discharge planning team. So every morning when the interdisciplinary team meets, the discharge planners ask the doctors, is this patient ready for discharge medically? If the doctors say yes, the discharge team kicks into gear and basically takes over at that point. They
hospital, but I think as internal medicine trainees here at UFT, we all know that there are also certain attendings at certain hospitals that cherry pick the residents to work with them. So to answer what was mentioned there, it could be that certain attendings who we all know could, cherry pick certain residents that could influence why they have better outcomes to other people.
Yeah, it's a great question. So we, in this data set, have not been able to account for differences in residents because it's very messy. And the assumption is that over large samples, the residents move somewhat randomly and those effects should wash out. But that, as you said, is not always true. And I agree that that's a potential explanation. And I think we just have to kind of look into it to see, is it possible that it's related to something linked to sort of specific residents? I agree with you. Yeah, I agree with both of those explanations. So I'm going to keep moving, but that's kind of that. So, the limit of some of this sort of big data work is like it highlights big differences or big opportunities. Then when you get to the point of trying to explain them, you're left trying to say, okay, well, how can we get more granular? I think we've been able to get more granular than a lot of other work in this area because of the detailed clinical data. So now we're also able to interrogate, do the people who have different mortality differences have different test ordering patterns? Do they have different ordering patterns, use of imaging? Do they have different use of medication? So we're able to start asking some of those questions, and that's kind of where this body of work is going. The other way that this body of work is going is towards provincial quality networks. So essentially, as Marie said at the very beginning, not a lot of attention has been shone on internal medicine in terms of quality improvement. So we essentially went to the province and said, please give us some resources so that we can build a community practice focused on improving quality in general medicine and use data to inform the decisions that are being made. We are developing practice reports, so each physician, and I have my practice report here, which I'm happy to show you if we have time, we'll get a report like this, sort of showing them their patients compared to their hospital, all of the conditions that they're seeing, and then some big indicators and sort of what are those so essentially, where do they sit in that distribution of those plots that I showed you before? It's also been a research platform for a lot of research projects and collaborations. And I was hoping to talk to you a little bit. We've gone very long. So maybe there's not time to talk about the patient-reported measures, which is unfortunate. I think it's probably just better not to and just pause and wait for questions because this is like another 10 slides. They look how nice they look. So maybe I can come back in unless people want, unless a question is tell us about this. I think I'll pause there and say thank you so much for your attention and for inviting me to come speak with you.
Quick questions about your portal.
Yes.
Is that based on the number of cases per physician see the patients or based on the mortality quartile?
So the quartile was based on the proportion of death for each physician. So it's the numerator and the denominator, right? So percentage of patients who died for each physician. So within each hospital, physicians are ranked by their mortality rate and then split into quartiles. And then that way you take everyone in quartile 1 at hospital A and put them in quartile 1 with everyone at hospital B, C, D, and F, and they all go into quartile 1. And then likewise. Does that make sense? Yes.
So back to that, so I'm assuming you looked at that same distribution of the characteristics and so on within each hospital?
Yes.
It's aggregating them, you maybe muddying the waters a bit because as you showed at the hospital, the 5 different mortality rates. And so the 2.5, the lowest quartile is a different set of patients potentially in each hospital. These patients do choose which hospital to go to, they don't choose which doctor to see once they're there.
Yes.
But so I guess it would have been convincing if you showed us
within each hospital
showing, you have a smaller sample size and there's more natural variation, but just to show that those characteristics don't differ much across the quartiles within a hospital as well.
Yeah, we have looked at it and it does look the same, and I think that's why it aggregates up to being the same. But yeah, that's a great. If you would find that more compelling, we could definitely show it that way. So, well, it's more granular. It's more granular. Yeah, it's a bigger supplementary appendix. Why don't we start here and then we'll come back to it. Yeah.
Thanks for this. I'm wondering if you had a chance to look at underlying team effects. So that could perhaps have differences in patient characteristics I know here, for example, we have like an oncology flavored team. So, is that also similar to other hospitals? Yeah,
very, very important point. One of the things I didn't mention is, so most hospitals have one or two teams that are weird compared to the other teams, right? Like have a specific type of, like, so there's an oncology team here. There's hospitalist team at Toronto Western Hospital. There's an orange team at Sunnybrook. Like we excluded those unusual teams from this specific set of analyses for comparison. Yeah.
So when I think about doctors, I mean, that's like a
great question.
It's not really a self-serving question, but I mean, I would have thought that most of the variation in practice, most of the problems in how we deliver care don't have much to do with the clinicians. Of course, there will be good and bad doctors, but I mean, things like use of NG tubes, early referral to CCRT, outreach teams. I would have thought that there are like a lot of things to think about that maybe have a higher priority than the quality. Like, because I mean, for the most part, doctors in downtown Toronto, I would have thought, are like not terrible, and there's a lot of other things to think about.
Yeah, it's a great. So
why spend so much time thinking about doctors?
Well, let me start. So yes, I mean, there's like I have like sort of 3 or 4 national answers, but I'm going to start with saying, how do you explain what we see there? Right? And the reason we started with doctors was because of a body of research out of surgery, right? And so there's a whole literature in surgery that shows that there are striking variations in care, even amongst physicians at the high-performing centers performing highly specialized surgeries, who you would expect are all going to be relatively comparable. And we know in surgery there are important selection biases, right? But in medicine, that selection bias doesn't, where the best surgeons take on the sickest patients, right?
Clearly there's a signal there.
Yeah.
I'm not saying that there isn't. I just, like, ex ante going into this, I would have thought, wow, nobody's studying all of this complicated stuff that we do, and there are so many questions to answer. And the stuff about hospital volume and physician, like, I mean, that's sort of the bread and butter of HSR, but it's just like, I mean, I would have thought that personally I would find other questions more interesting.
I think, so it's totally fair. The reason we came into it, we actually didn't come into it focused on physicians. We saw these plots and then said, oh, we should chase that because that's striking. But we came into it because we knew that there was a lot of physician variations work done in other areas that had really not been done in medicine. We thought, well, let's look and see. There are a few other reasons. One is physicians tend to be the holders of a certain amount of cachet in the system, and so if you can get them engaged, it's easier to get resources behind your work. So there was like a tactical, strategic potential reason, and then I think the third reason is a pragmatic one, which is it's easiest to measure at the physician level right now, as compared to trying to tease apart all, like, we don't have data about the pharmacist and the physiotherapy and all that. So it's harder to get that data. Doesn't mean it's not important, and we hope to go there. But I think for a variety of reasons, we kind of have landed on this framework for now. Yeah.
Have you grabbed information pertaining to ward size and nursing workload and nurse to patient ratio?
Yeah,
as part of your analysis, in the sense that, you know, you may have a ward of 50 beds, and because of whatever reason, your workload measurement for the nurses are overwhelmed versus a 20-bed unit. And to correct me if I'm wrong, but general internal medicine, do you go amongst the wards, or do you kind of have your favorite ward because the nurses think you're the favorite person that they want to be with all the time, or whatever the combination there is? Like those strange factors that deal with the teamwork part.
Yeah, great question. Generally, at these hospitals, physicians, so the patients are cohorted on a couple of wards that tend to be the medicine wards, and physicians have patients scattered throughout those wards. So the ward effects are unlikely to be big, have a large explanation at the physician level variation. Right. But there are ward level, and we did collect, so I mentioned we have the ward level data in terms of, in the ADT data, we have all the room numbers and everything, so we can do ward level analysis. The nursing data is a lot messier and very, like, almost challenging to standardize across sites. So we didn't do it in our first round of data collection. It, I think, is important and really worth exploring, but we haven't done it across sites yet.
stole that from OCCI, right? Like your OCCI will have levels of nursing care that are provided, or if you look at the workload, well, depending, I worked at Sinai, so the nursing would have certain levels of nursing workload that you could pull from the OCCI data to get at some of the nursing level information. It's kind of
that based on kind of like the graph.
Yeah. It's not perfect, but it's like a metric that you have tied to the individual day as to what was assigned to that patient, and sometimes it's averaged out and stuff. But
it's a really neat idea.
It's a variable to grab that gives you ability to go back in time.
For sure. Thank you. Here and we'll come back to
moving forward, do you anticipate any pushback in your data collection for the potential fear of linking your data to a physician's performance metric?
Yeah, it's interesting. I mean, so if you pushback from who, I guess, is the question. We are creating these physician practice reports. We are not calling them performance reports because I don't think that's exactly what they are. I think they're practice reports that help us reflect on the care that we're providing. We're being very cautious about how those are being used and who they're being shared with. They're confidential reports for each individual physician meant for the purposes of quality improvement. This is, I think, going to be sort of this whole idea of audit and feedback of clinical practice is coming sort of as a widespread culture. So you're seeing it in surgery, the National Surgical Quality Improvement Program. In Ontario, they deliver primary care practice reports, long-term care practice reports. And what we felt was that this would be better to be led by physicians than to be sort of top-down, administratively driven. And so that's kind of, but yeah, there are people who are nervous about it. I think it's just about making it clear that this is formative and not for sort of punitive reasons. I think the other part, though, is most physicians, like, I want to know the outcomes that and care that about the care that I'm providing. I want to know more information. I spend a ton of time training. It's like what I spend a lot of my time doing. I'd like to know sort of so I can improve and or whether you know what I mean. I'd like to have the ability to have some discussion. And we've shared these data with so we've done a pilot with the practice reports at St. Michael's, and we did surveys, and so 16 of the 16 physicians said that they found the data useful, that they wanted to receive it again, and that they found something they could improve based on that. So we haven't yet seen a huge amount of pushback, but I think it's because we're doing a lot of frontline engagement around it.
Path two. So that was really super interesting for me, and I'm sure interesting for most of you. And so let's thank Amol again for